Hello everyone, my name is Elizabeth Lanier and I'm going to be talking about my plan on preventing venous thromboembolism in my practice environment. The purpose of this project is to prevent all occurrences of venous thromboembolism, which is also known as VTE, in patients who are admitted to a burn intensive care unit in a local hospital. Describing the practice problem. VTE is a blood clot that occurs in the veins, including both deep vein thrombosis, or DVT, and pulmonary embolism, or PE. This problem affects approximately 900,000 people every year in the United States. Mortality rates differ depending on the specific diagnosis. In 2013, the mortality rates for DVT ranged from 13 to 47%, and for PE, mortality rates were about 25%, accounting for 25% of all hospital-related deaths. Research shows that less than half of patients who are hospitalized receive preventative measures for VTE, and as many as 70% of these cases can be prevented. This is an often overlooked major public health problem, as VTE accounts for the most common preventable cause of death for patients that are hospitalized in the United States. This problem costs about $10 billion or more every year in the United States. In 2015, DVT and PE were found to increase median hospital costs by about $7,500 and $19,000 respectively. The clinical question applicable to this study is, will the implementation of a VTE prophylaxis bundle, including mechanical prophylaxis, pharmacological prophylaxis, and early ambulation, prevent occurrences of VTE and their complications over the next 3 months in patients who are admitted to a burn intensive care unit? An evidence search process was done using SINO and the Nursing Reference Center, and this yielded thousands of articles. Only some of these were relevant to my clinical question, and only 8 of these articles were used in the research process to determine these practice recommendations. Based on the data I found in the research, I came up with the practice recommendations. According to Stanton in 2017, it was determined that VTE prophylaxis should include both mechanical and pharmacological prophylactic measures. I also found that early ambulation should be encouraged in patients who are able to do so, as immobility is the largest factor in hospitalized patients developing VTE. VTE education for nursing staff is also significant in the prevention of VTE in hospitalized patients. The Institutional Review Board was not involved in this project, but if the activation of a policy containing a VTE prophylactic bundle was going to occur, IRB involvement would be necessary. Ongoing research in a small pilot study would need to be conducted before this is found effective, and a policy could be initiated in the hospital dependent on the results. In order to have this project implemented on my unit, I first approached my unit manager. She happens to be the nurse practitioner on my unit as well. I brought to her my idea, provided supporting evidence, and devised a plan as to how this was going to be implemented. I produced a note with the changes for staff to read, because when there are changes on my unit, that's how things are done. Staff is to read, sign, date, verifying that they're aware of the changes. My manager is also there most mornings to remind staff about what is happening, but it's impossible for her to see everybody. The staff is notified 1 week prior to implementation. There are reminders for continued medication administration, as these are ordered by providers. There are interventions in our computer system to be documented for mechanical VTE that is ordered. Emphasis for early ambulation in patients was also encouraged to all nursing staff. I did find an article that was provided for the staff with a note, and I also posted this in the employee break room for everyone to read. This was regarding the best VTE prophylactic measures. This was provided for information and just in case anyone was resistant or hesitant to the change. I also had support from everybody providing patient orders, such as my unit manager, the attending physicians, and the residents. New equipment was not needed that the hospital did not already have. I just had to check in all the patient rooms to make sure that necessary equipment was in all of them. I obtained replacements for the devices that were missing. There was essentially minimal extra work for nursing staff, as nurses are already administering ordered medications and applying ordered mechanical prophylactic VTE prevention methods, and documenting that this is done. This accounts for maybe an extra 30 seconds spent with each patient. Methods for evaluation. The instrument that was used during the study is a chart that I made that I'm filling out on a weekly basis. This consists of suspected VTE cases, actual VTE cases, and I further broke it down to whether it was a DVT or PE. In order to find out if this project is affected, no patients would develop VTE. This would also indicate quality improvement. Staff compliance would also indicate that this practice change is effective because they wouldn't be doing it if they didn't believe it was right. The cost would also have to show that they outweighed the benefits. In order to do this, I would have to determine the cost of VTE prophylaxis prior to the study taking place and compare it to after the study was finished in 3 months. I would also have to consider the cost of VTE treatment. In order to find if the practice change would be sustained, several things would have to occur. Support from all staff is needed. Not only would nursing staff have to apply with the project changes, which hasn't been a problem anymore, but after 3 months, the practice change would have to be shown effective. If extra costs incur, they must outweigh the benefits when comparing to the cost of treating someone who has developed VTE. And lastly, to show that this was effective, this could eventually be a policy that is implemented in all the intensive care units in the hospital. Thank you everyone for listening to my presentation.